Hey guys. For anybody who doesn't know me, I'm Sheena Hilton. I work labor and delivery usually on weekend nights, so I may not have met all of you, but I am also in a DNP program for nurse anesthesia. My last project here, local anesthetic systemic toxicity, is for my DNP project, and I have to have this for graduation. So I hope you guys enjoy this and learn a little something. All right, so our next slide is local anesthetics. What are they? Well, most of you have worked with local anesthetics, working on labor and delivery. We use a lot of those in our epidurals and spinals. But here's just an overview of things that you may not know about them. They're used to produce anesthesia and analgesia. They're lipophilic and hydrophilic. They have the molecular structure, and those are separated by connecting hydrocarbon chains. There's two different classes, the esters and the amides. Those are determined by the intermediate hydrocarbon chain, and it determines where the local anesthetic is metabolized. And then it can also play a role in the allergic reactions. So the esters, and just to give you guys a tip, esters and amides, the way to know the difference between those without just remembering them, I need little clues to remember things. Amides have an extra I in them. So all of them end with cane, which has an I, but then amides have an I before the cane. So they typically have two I's in them. Um, so esters are metabolized via the hydrolysis in the cholinesterase in the plasma. And that is a very fast metabolizing agent. So where this becomes important is that the amides, which is what we typically use, they are metabolized in the liver. And this metabolism is way slower, which means that your drug can accumulate more, making toxicity more likely. So I just said it, but what local anesthetic is typically used in labor epidurals at Rex? Well, that is bupivacaine. And then does this drug fall into the category of a faster or slower metabolism? Well, we have two I's, so we're an amide, which is slower metabolism. So a local anesthetic, what is their mechanism of action? Well, they bind to voltage-gated sodium channels. When you block those sodium currents, this leads to reduced excitability. So, meaning they inhibit the sodium ions from passing through, and this causes a slower rate of depolarization, making pain not propagate. Um, so, I mean, this slide goes into a lot more detail on that, but in a nutshell, that's what happens. All right, how does blocking sodium channels block our pain sensation? So they suppress our action potentials from happening by blocking those sodium gated channels. In doing so, they inhibit action potentials in nociceptives, which are our pain fibers, and that blocks the transmission of the pain impulse. And then, said another way, local anesthetics prevent our pain by blocking the transmission of pain signals to the brain. All right, bupivacaine. What do you need to know about it? Well, it's an amide. We've already gone over that. Our onset for epidurals is 4 to 17 minutes, and a spinal is less than 1 minute. You guys know that. You've seen the difference in a spinal and an epidural. Our peak for an epidural is 30 to 45 minutes, and in a spinal is 15 minutes. The duration is going to be 4 to 8 hours. Our half-life is about 3.5 hours. Comes in different concentrations. Two of them are here. There's more out there, but you've got 1/4%, 0.5%, and those end up being 2.5 milligrams or 5 milligrams. We'll go over the math in just a minute. Our maximum dose is going to be 2.5 milligrams per kilogram or 175. And my rule of thumb is less is more. I don't want to get to that max dose, even though you've got, say, a max dose by doing it per kilogram is going to be 200 milligrams. I'm going to stay within that 175 milligrams just to be on the safe side. And then dosing. Typically, as anesthesia providers, we dose an epidural 50 to 150 milligrams, or for a spinal, it's 7 to 15 milligrams. And then here's our calculating the dosage. All right, so bupivacaine, it comes in 1/4%. To me, I just think it's easier to do the math by moving my decimal point over just one to make it 2.5 milligrams per ml. But here's the more of your math if you'd like to do it and calculate it out per 100 mLs and get your 2.5 milligrams per ml that way. So let's go into, if we're doing a 5 ml bolus, call the anesthesiologist, that's what they tell us to give. Well, if we're giving 1/4%, we're 2.5 milligrams times our 5 mLs, we're giving a 12.5 milligram bolus. All right, so we'll do some math here, okay? Your patient is a G1P0, 39 and 5, 8 centimeters. They weigh 80 kilograms. Let's make this math easy. She received an epidural about 6 hours ago, and she's done 3 boluses, but she's hurting. So you call up your anesthesiologist. They give you an order for a 10 ml bolus of 1/4%. And so you want to calculate how many milligrams that is. So here's what we're going to do. We've got 0.25% bupivacaine. You're going to calculate it out whichever way you'd like to, moving the decimal or doing the whole thing. You know, get your piece of paper out and get ready. Anyway, you've got your ordered dose. We're doing 10 mLs of 2.5 milligrams. So that makes 25 milligrams. Well, what is your maximum dose, and is your dose safe? Our maximum dose is 2.5 milligrams per kilogram, which for this patient being 80 kilograms is 200. But to be on the safe side, I'm always cautious. I can always give more, I cannot take it away. So I'm going to steer clear of the 200 milligrams and make my max dose 175. So we're nowhere close to that. The one thing to keep in mind when you're dosing these epidurals is that we're running an epidural dose, a basal rate in the background. They've also given themselves 3 doses of, our bolus doses from our PCA option. And now we're giving them another 25 milligrams. I mean, our anesthesiologists are very good. They're not going to give you something that's too large, and they have standards on what they're going to give you. But this is why it makes it really important to not give more than what they're ordering. If you need more, then you need to call them, and typically they really need to come back and change out this epidural to make our patients more comfortable, or at least come to the bedside to troubleshoot with you. All right. So the whole purpose of this talk is about LAST, local anesthetic systemic toxicity. So this is caused by an excess plasma concentration of local anesthetic. Plasma concentrations are determined by the rate of entrance and redistribution of the local and its metabolism. The most common reason for toxicity is it being injected intravascularly. And that can happen during nerve blocks, during epidurals, during spinals. Any kind of nerve block can cause this. So factors that are influencing our toxicity are the dose administered, how vascular that space is, presence of epinephrine, And then the other properties that make our locals more potent, onset, the duration of action, things like that, PK and protein binding. So with pregnant women, they're at increased risk because the epidural veins become engorged during pregnancy. So during an epidural placement, anesthesia providers are asking patients, well, one, um, we're doing our test dose, which has epi in it. This is why we're looking down at a pulse ox to see what our pulse rate is. We ask the patient about any numbness, tingling around their mouth, metallic taste in their mouth, things like that. That is why our test dose is there, to make sure we're not in an intravascular space. All right, so now that we know what can cause toxicity, let's talk about the signs and symptoms. So we're going to have neurotoxicity symptoms, and then we're also going to have cardiovascular. So our minor ones are our numbness around our mouth and our tongue, some tingling in our fingers, some restlessness, anxiety, blurred vision, ringing in the ears, and then the tremors. So let's bringing it to the attention is that we always have our patients that are shaking right after or whatever. These tremors are going to be big tremors. These are like right where you might be like, is this person having a seizure type of tremors? This is not like our small shaking that we're used to. All right, then we're going to get into the major signs. Tonic-clonic seizures, global CNS neurodepression. So this is where our patients we're not able to arouse them, or they just get real sleepy all of a sudden. You can arouse them, but they're real groggy. Some hypotension, which I'm going to talk to you about because we're typically used to seeing hypotension, but as we'll see in a second, you typically have hypertension first in this. And then on so on, you can get into apnea. Let's hope we never see this in our careers, guys, but it has happened actually at Rex. I think in the past few months, it's happened 2 or 3 times over in the main OR PACU area. So initial excitatory manifestations that you'll have, which is because there's an inhibition of GABA release. All right, and then we're going to get into our cardiovascular toxicity signs. All right, our early signs are going to be tachycardia and hypertension. So if you're seeing hypertension, tachycardia in your patient after an epidural, like typically we're used to there being some hypotension, but you're seeing hypertension, your radar needs to go off. Just be like, something ain't quite right. Let's keep watching. Ask your patient if they're having any of these other signs of tingling, ringing in their ear, blurred vision, feeling like you're going to pass out type of things. Later signs, you're going to have your vasodilation with your hypotension. Then they're going to become Brady, and then it goes downhill from there. We're not gonna see the ventricular dysrhythmias. We're gonna see our patients passing out, and our baby's not doing well. So these are things we don't want to get into. So now let's name some minor and early signs and symptoms of toxicity. You think you can name those for us? All right. So our CNS, we're gonna have tongue and oral numbness. We're going to have tingling in our hands, restlessness and anxiety, ringing in our ears and blurred vision, tremors, and muscle fasciculations. Then our cardiovascular early signs are hypertension and tachycardia. Now, some major or late signs of toxicity are CNS. We're going to have seizures, CNS depression, hypotension, decreased level of consciousness, apnea. And then our cardiac late signs, we're going to have that profound hypotension, bradycardia, conduction defects. These things that of the prolonged QR or QRS, PR or QRS, or ventricular dysrhythmias, we're not going to see because we're not doing cardiac monitoring unless you're in the PACU, because these things still can show up in PACU. So you just want to make sure that you're looking at that and realizing if things have changed. All right, so if you notice any of this happening, what are you going to do? First, you're going to call for help. We're going to call the charge nurse or other nurses in there to help, anesthesiologist, and your OBGYN. You want to make sure that you've got oxygen in the room, because these patients, they'll go apneic and they need either to be bag ventilated or at least have some oxygen on. This will prevent them from becoming acidotic, which we see lower in the list here. You want to make sure their suction's available, because if they somehow stop breathing, start having seizures, and start vomiting, they could aspirate. Then we get into another bad situation. You want to call somebody, they need to go get the last rescue kit. We'll talk about that as well. Avoid acidosis, which I've already mentioned. If they start having seizures, benzos are preferred. So, Ativan, Versed, things like that. If we don't have that available, then propofol is our next best friend. But the thing is, propofol is going to cause more hypotension. That's why benzos are preferred. Then our intralipids. We'll talk about where to get these, but here's our bolus of 100 mLs over 2 to 3 minutes, and then infuse 250 mLs over 15 to 20 minutes. And then we go into ACLS if our patient becomes pulseless and we need to run a code. We do want to avoid any calcium channel blockers, beta blockers, or vasopressins. And then, on down the line would be cardiopulmonary bypass. Like I said, hope none of us ever see this. Anyway, here is the ASRA flow sheet of what to do. These are going to be located, and I'm going to put it in the slide down here at the end, but these are going to be located at the charge desk and then near every Pyxis. So when you go in there to get your intralipids, grab this list, okay? And this goes through everything that I've already said. All right, so we run into this. God forbid we actually see this in our career, but what are we going to do? What's our role? All right, we just went through it. We're going to tell the patient after their epidural is placed, we stay in there for 15 minutes, vital signs every 5 minutes, heart rate every 5 minutes. The other thing I want to point out is that the vital signs every 5 minutes and fetal heart rate every 5 minutes is for boluses as well, because this can happen with a bolus. This is not just right after placement. This can happen up to an hour after placement, or it can happen up to an hour after you do your bolus. So anyway, so after the placement or a bolus, you're going to inform your patient to notify you immediately if they experience any tingling around the mouth, changes in taste or vision, or feel like they are going to pass out. So things to alert you about. You need to be familiar with treatment protocols, even though we don't see this at all, if any, but those are the reasons to be familiar with it. And then, so when we get a bolus order, you want to inject 5 ml increments. You aspirate before you inject to make sure there's no blood that is being aspirated. If there is, stop and call your anesthesiologist. Next, In between each 5 ml increment, you want to aspirate as well. You want to understand the signs and symptoms I've already gone over about toxicity, and know the location of your last rescue kit and ASRA checklist. All right, like I said already, the rescue kit is located in Pod D, and in PACU, you got your intralipids. You're just going to type in fat, lipid, or intra into the Pyxis, and it comes up. And it's white. It looks just like propofol, but it's intralipids. And then you're also going to grab this algorithm, the ASRA algorithm for dosing and next steps to take. Those are going to be available at the charge desk and near all the Pyxis. All right, next. It's another scenario. Emily's 19 years old. She's a 40 and 5, G1P0. She's 9 centimeters. Baseline blood pressure is 116 over 68. Her pulse is 82. She received an epidural 7 hours ago. Now she's hurting, even after 3 self boluses. So you're going to call the anesthesiologist and get an order for a 1/4% bupivacaine bolus. He gives you 5 mLs. All right, you give the bolus, but you forgot to aspirate before injecting. Your patient begins to have a seizure. Now, what do you do? And yeah, you might pee yourself a little bit, but that's okay. All right, you're going to call for help. Don't touch your patient, but make sure they're safe. So, the big thing with seizing patients is don't disturb them, but definitely make sure they're not going to hit their head. They're going to, like, you need to make sure you're taking precautions so that they are going to be safe, but you don't want to touch them. Have somebody grab the last kit, crash cart, and a benzo. I mean, we need to be calling people to come and help. Anticipate for your benzo order. You're going to anticipate to give those intralipids and anticipate for a code green or bedside delivery. So that is all that I've got right here. I will be available for any questions. I know this is recorded, so it may be difficult to ask me questions, but just email me, text me, whatever. I'll get to you and I'll get you your answers. But I hope that you guys learn from this, and can use this in your practice coming up. There is going to be, so you've done the pre-survey, hopefully, before you've watched this. And then there's going to be a post-survey around 30 days after this has gone out, and I'll post it on the Facebook page and email it out. If you guys can do that, it would be greatly appreciated. I appreciate all of you always, and I hope that you enjoyed this presentation. Thank you.